Well, welcome back to the podcast, Pod Girls, Pod Boys, Pod People. It's your boy, Dr. Mark List. Today's joke from the primarycarepod@gmail.com inbox is a joke that was sent to me by an anonymous listener, Dr. List. The last wedding I was at was very emotional. Everybody was crying. The bride, the groom, the priest, even their massive cake was in tears. Okay, same bad jokes. All right, let's start the podcast.
The Primary Care Podcast is written and edited by a family physician for an audience of other physicians, nurse practitioners, physician assistants, residents, and medical students interested in primary care topics. This is not a podcast for patients and should not be used as medical advice. This is also a personal podcast produced on my own time and solely reflecting my personal opinions. Statements of this podcast do not reflect the views or policies of my employer, past or present, or any other organization with which I may be affiliated.
Thank you for listening to the Primary Care Podcast. I'm Dr. Mark List, here to bring you the latest news, guidelines, and updates from primary care sources around the globe. Keeping it under 15 minutes long because you're in a hurry and I'm not that smart. Well, welcome back to the podcast, Pod Girls, Pod Boys, Pod People. It is your boy, Dr. Mark List. And today's episode, I've been away, taking a little break from the podcast, having some downtime over the summer. Hopefully everyone enjoyed the rest of their summer. As we get back in towards normal routine, I'm currently on not a vacation, but a work trip. I'm actually doing some physician coaching, EMR assistance up north. And so as I'm sitting in my hotel room here, I thought I'd get back on the podcast train. And an episode on what I think is a really important topic, and a topic that I probably deal with pretty routinely, actually. And some of you may or may not have to deal with this. Depends on your organization and your rules within your organization. But this is an evidence-based guideline, and this was a cooperative clinical practice guideline from the American College of Gastroenterology and the Canadian Association of Gastroenterology. So a combination of those two groups got together, and this is a suggestion for peri-endoscopic management of anticoagulants and antiplatelets. So this study was April here of 2022, so about 3 months old now, published in the American Journal of Gastroenterology. And with this comes a couple of changes that they recommend. And I'm going to scroll down here, and they talk about two different times when you'd use these guidelines. The first whole set, which I'm not going to spend a ton of time in, is when the patient is currently hospitalized or at least under observation with an acute GI bleed. So what do you do with somebody who's on warfarin, who's on a DOAC, who's on aspirin, who's on antiplatelet agents, and they have a GI bleed, and so they need an endoscopy, right? They need some kind of EGD, colonoscopy, etc., right? And then what I'm going to focus on, at least at the beginning, if we have time, I'll dig into those, the acute GI bleeding ones. But then the other scenario is, well, what about patients having elective GI scopes, right? So they're having upper scopes, they're having lower scopes. What is the recommendation for, based on these experts and what evidence is there for the management of warfarin, DOACs, dual antiplatelet for secondary prevention of strokes, etc., and then just plain old aspirin, right? And so this is not what I am seeing in my neck of the woods in terms of clinical practice. And so these guidelines are going to help me at least maybe feel more confident with my patients and telling them what the recommendation is from the national experts and actually international experts, and hopefully then maybe change the mind or at least qualm any fears from my local endoscopist. So for all patients on aspirin, whether it be 81 milligrams to 325 milligrams, and this is specifically if they're on aspirin, even for secondary prevention of any ASCVD event, so known coronary artery disease, known heart attack, known stroke, all of it, all of the recommendation is to continue aspirin for their elective colonoscopy or EGD, which, again, in my neck of the woods is definitely a change, and I don't see that happening. The evidence for this, based on this review, is very low. So, again, not the best level of evidence to support this, but definitely what they are recommending. What about if they are on dual antiplatelet therapy for secondary prevention? So if they're on, a clopidogrel plus aspirin, or if they're on ticagrelor. Oh man, I even practiced that before I launched the podcast. Ticagrelor or prasugrel. Oh, you know me in pronouncing drug names. So any of the P2Y12 antiplatelet drugs, right? The most common one I see used around my neck of the woods is clopidogrel, Plavix, and so they actually recommend stopping the Plavix, any of those specific drugs, but continuing the aspirin while they're having that elective endoscopy. Okay, for DOACs, they actually recommend temporary interruption of the DOAC. So again, your dabigatran, your apixabans, etc., they actually recommend discontinuing that temporarily and then restarting after the procedure. For warfarin, they actually recommend continuing warfarin for procedures with low to moderate bleeding risk. So that means colonoscopies and EGDs. And if the warfarin is interrupted for a procedure for very high risk of bleeding, so for example, if there's a bigger thing that they're going to remove, or if there's a known risk for large bleeding with the procedure, they actually suggest against bridging. So I think that's pretty crazy. So even if the procedure, even if the GI physician, the endoscopist, the general surgeon, the family doc, whoever is doing the scope themselves, thinks that there's a high risk for bleeding and they want to interrupt the warfarin, they actually don't recommend bridging unless the patient has a mechanical heart valve. So all these things are big changes for me. And in my neck of the woods, right, I usually sign the patient up for a colonoscopy or an EGD, and then I send off the referral. And then sometimes I will get a message back. I normally don't have to do a pre-op H&P for endoscopies. Normally the person who's doing the scope just does those the same day. But I oftentimes get a notification or a message asking me to stop their warfarin, asking me if it's okay if I stop their warfarin or stop their Plavix or stop their aspirin, stop their, their Xarelto, their Eliquis, etc. Sorry if using trade names. But now with these guidelines, I think I'm going to be very clear that I can, send a message back to the GI doc saying, based on these recommendations, the only thing that I'm going to be stopping is their clopidogrel, their Xarelto, their Eliquis, and unless they have a mechanical heart valve, and I only have a couple of patients with mechanical heart valves, not even discontinuing their warfarin or their aspirin. So these are really good guidelines to know that the American Gastroenterology College of Gastroenterology agrees with these guidelines not to change things. I also think that it's reassuring to patients that there are expert opinions not to stop these. Obviously, you can have conversations with your local docs about this and have more conversations with your patients, but this will likely be a game changer for me anyways, and we'll see if this continues to change locally. I'm not going to spend a whole lot of time, but they did talk about how to manage your patients on warfarin or DOACs or on your antiplatelet agents or on aspirin who have an active GI bleed, who then need a endoscopy, whether it be an EGD or colonoscopy. And they actually recommend a lot of this prothrombin complex concentrate if you have that available in your organization, instead of like FFP, fresh frozen plasma for warfarin, or vitamin K, which is what I historically, whenever when I was in residency, I knew that when people were in with a GI bleed and they were on warfarin, we used a ton of vitamin K or FFP, but they are actually suggesting PCC, this prothrombin complex concentrate, over fresh frozen plasma FFP. And for DOACs, they actually recommend against the PCC and basically suggest using anything, either for dabigatran, rivaroxaban, apixaban, basically trying not to use anything. The recommendations are suggest using against PCC, suggest using against the two reversal agents. For antiplatelet agents, right, so your clopidogrels, etc., again, recommending against using platelet transfusion. And then for aspirin, suggest continuing aspirin for secondary prevention. For primary prevention, okay to discontinue. If aspirin is interrupted, suggest resuming aspirin on the day hemostasis is endoscopically confirmed. So again, these are much less aggressive in terms of they're a lot more lax on leaving patients on their anticoagulants. That's good news for us in primary care. That's good news for patients, a lot less confusion. And I think that should just all make us feel better about our patients and their risk for bleeding undergoing surgery who have to take these medicines. So again, quick recap. For elective procedures, whether it be EGDs or colonoscopies, if they're on warfarin, continue warfarin unless the procedure list thinks there's a really high risk for bleeding, in which case you can discontinue warfarin, and they recommend against bridging unless the patient has a mechanical valve, in which case obviously go back to your Lovenox shots, etc. If they are on a DOAC, definitely still need to stop that for the short term. If they're on dual antiplatelet therapy, just stop their Plavix, etc., but can continue their aspirin. And if they are on aspirin for secondary prevention alone, suggest continuing it. Major GI bleeds, this is something I'd definitely look up. If they have an active GI bleed and they're on an anticoagulant. But basically, a lot of the experts are now saying don't use much. Don't use FFP for warfarin like we used to. Don't use platelet transfusions if you can get away with it. And even an aspirin for secondary prevention, recommend continuing it. Or definitely restarting it as soon as you confirm hemostasis. For DOACs, basically stop the DOAC and try not to use the reversing agents. Those are, again, very low recommendations. But again, overall, good changes for us, good changes for patients, and at least everything is safe, it sounds like, based on the risks and these studies confirming the trials. So this has been Dr. Markless, Primary Care Podcast, reminding you don't need to stay up all night to stay up to date. Thanks and have a great week.